Thank you very much, and good afternoon, everybody. It's truly a pleasure to be here. As was mentioned, this is going to be a brief discussion of the evaluation of total joint arthroplasty with a bit of a focus on kind of how we evaluate for periprosthetic joint infection. So in brief, we're going to talk about the role of the revision specialist, hone in on some of the specific modes of failure that you're really searching for. So when you're evaluating these patients, it's not just sort of fumbling around in the dark. You're looking for very specific things, both intrinsic and extrinsic to the joints, and hopefully outline a systematic approach with some of the current diagnostic tools. And all of you have a good sense of how to do this, but hopefully there will be a couple of points that might be useful to you as you go back into your own practices. So it seems like the revision specialist needs to be both motivated and thoughtful. You need to be motivated to find the answer because it's pretty easy to stop short of figuring things out when it's not crystal clear. And to be thoughtful, it really requires going into these cases with a broad differential diagnosis, understanding those specific mechanisms of total joint failure, which can be multifactorial sometimes. And at times, these diagnoses can be elusive. It can require multiple visits and tests, and sometimes collaboration with other medical specialists. And it's crystal clear that not all painful joints need another operation. If you don't know what's going on, you either need to send that patient along or keep following them up, but do not take them straight to the OR. It's best to avoid this situation, which is putting your head in the sand, and I think it's probably fair to say it's most common with your own cases. So it's much easier for me to diagnose flexion instability in somebody else's patient than in my own. As we noted before, we are searching for very specific modes of failure, and these can be intrinsic to the joint, or it can be extrinsic, like this case of neural impingement. And you really need to have this list in mind when you're going into the room, because this is what you're really trying to figure out. Does this patient have loosening? Is there an infection, instability or fracture, bearing surface issues with polyethylene, ceramic or metal, or taper corrosion? And you can see a couple of pictures here. You can see the radiograph of this loose and subsided revision femoral stem, and hopefully it shows through pretty well, but that's a bald eagle trochanter from a patient that had symptomatic taper corrosion. Some other less common intrinsic failure modes: abductor issues, leg length, heterotopic ossification. I point out iliopsoas impingement. This one seems to sometimes slip through as a cause of enigmatic groin pain, especially activity-related hip flexion, getting in and out of a car, getting in and out of bed. This one sometimes slips through. This particular view, the cross-table lateral x-ray, can really start to highlight that sort of uncovered anterior socket that can cause pain. So don't forget about that one. Around the knee, it's a lot of the same things: infection, instability, like patellofemoral instability you can see in the top there, mechanical problems like aseptic loosening, which you can see in the bottom, arthroplasty, fracture, extensor mechanism disruption, or malalignment, and in particular, massive coronal plane or rotational malalignment problems. When it comes to the extrinsic pain generators, there's obviously a whole bunch of them. I would say seems like the two most common that I would see would be hip arthritis that shows up as a painful total knee replacement. Seems like a couple show up in clinic every year that end up getting a new hip and feeling better. And then the other one, a common one, is spine or neurologic conditions. But again, there can be a lot of things that can be causing pain that you have to keep in mind as a revision specialist, not just say that it's not their knee and move right along. So now that we know those specific things that we're going to key in on and try to look for, how do we get there? It definitely requires a systematic approach. Realistically, it's things like history, physical exam, imaging, that infection evaluation we really want to hammer home, and then metal evaluation in specific patients. Very quickly, just a couple of key points that I think can be helpful for most surgeons as you're looking at these patients. So figuring out how their life was prior to total joint replacement and getting old films can be very helpful. As you can imagine, a patient that had bone-on-bone arthritis that now has a painful knee replacement might be different than the patient that has a total knee they don't like and pretty normal pre-op x-rays. Really keying in on those infection risk factors is going to really figure out how hard you're going to look for infection in that patient. So have they been diagnosed in the past with infection, a prolonged history of treatment with antibiotics, especially those patients that had early reoperation or wound healing problems, and figuring out if they're coming into clinic still taking their doxycycline, because if they are, then your evaluation for infection just changed a little bit. Figuring out if they've got a history of instability of the hip or the knee. One of the big hallmarks for knee instability are those patients with recurrent effusions. The lady who's pictured below there is not too hard to figure out. Acute on chronic pain is a big deal. You might have seen a patient diagnosed a loose socket, and then in the meantime, before you get them revised, they come in with acute on chronic pain. Those patients, it's important if you can't figure out a mechanical reason to reevaluate them for infection. Getting a hold of the old op notes and implant records is critical to know what's in there now. Did they have any previous complications with their surgery? Don't want to go into too much detail on physical examination. It's clear that a comprehensive examination from the spine on down is going to be important. And then again, highlighting kind of specific testing for flexion instability of the knee, I think is very important. Standard radiographs around the hip here would be kind of these 4 imagings. So an AP pelvis, an AP of the proximal femur that includes the entire implant, oblique and lateral views. Judet and false profile views are very important if you're trying to rule out pelvic dissociation. The 2 left views are standard Judet films, and you still have a hard time seeing around the corner for that posterior column. The picture on the far right is the so-called false profile view, which is even more oblique, and that allows you to get a better look at that posterior column. Advanced imaging around the hip is useful, but not necessary except in certain situations. I kind of wrote a couple of the indications for ultrasound, CT, MR, and bone scan there, which are pretty typical. But again, that's a very small subset of patients that are being evaluated. The typical evaluation for the painful total knee replacement is a standing hip to ankle, and then 3 views of the knee. You can see this patient with a loose femoral component and a loose tibial component here. Again, advanced imaging, while important and useful in certain cases, is probably used in less than 10% of patients. The infection evaluation is critical. You need to confirm that they're not taking antibiotics within the past few weeks. Otherwise, it muddies the water, and so it's very important to get that known before you make any definitive conclusions about infection. All painful joint replacements are infected until proven otherwise. And again, you want to maintain a high index of suspicion, even if everything else is looking good, if they've got some of the risk factors listed below. When it comes to laboratory evaluation, every one of these patients should get a SED rate and CRP. You can see the threshold values there. And again, I'm going to aspirate these patients if either one of those is up or if I've got an elevated clinical suspicion based on my history, regardless of what their lab values show. You can see some of the threshold values for aspiration based on the timing of surgery listed here, both cell count and elevated neutrophil percentage. You're going to want to hold those cultures for a while and keep in mind that somewhere plus or minus 10% of infections are culture negative, but again, many of those patients were on antibiotics when they had their infection evaluated. This is a picture of Dr. Meneghini with his favorite pastime, which is metal detecting on the beach, but I'll save the metal evaluation for another time. So in summary, when you're evaluating patients with a painful total joint replacement, keep in mind that they're all infected until you prove otherwise, and you need to understand whether or not they're taking antibiotics when they're seeing you in clinic. You want to explore those intrinsic and extrinsic sources of pain and have a systematic approach to those patients. Thank you very much.